Yeah, good evening everyone and welcome to Smart Learning course of ISU, this time with Dr. Badlani sir from the USA, and it has been coordinated by Dr. Arvind Panda, and I request him to please request our secretary who is here for his opening remarks and then take over the program.
Good evening, everybody. I know after a long time I'm back to the school, and nice to see our principal is still there. Not the principal, is the headmistress, ma'am Sujata. So this is I can say that it is very underdiagnosed conditions, and majority of us don't understand the problem. So that's why there's a need to review this thing, and who else can do the review better than Professor Gopal Badlani sir. I have great respect for him and for this subject also. And of course, other Indian scholars are also there. And I'm sure the participants will be greatly benefited, and it will be benefited. But everybody, including me, will be benefited from these discussions. And with this short introduction, I think we can, without wasting much time, we can go to the guest discussion. Thank you, everybody.
Um, Thank you so much, sir. It's my privilege to introduce Professor Gopal Badlani. From his MBBS days in the Topiwala National Medical College in 1974, he later completed his surgery from Nair Hospital, and from there went to the Long Island Jewish Medical Center in 1980 to complete his urology. He also had a board certification in female pelvic medicine and reconstructive surgery, and he's currently the co-director of pelvic health urology and professor of urology in the Wake Forest Institute of Regenerative Medicine. He also holds a position in the Office of Global Health of Wake Forest. Apart from all this, he has been the president of the American Urological Association, and he has had great fondness for India and Indian urology. He has been instrumental in helping a lot of us it, uh, gain experience in the United States. I myself was privileged to visit him at his center for a short time. Uh, Whatever I say about Professor Badlani will be insufficient for a man of his stature. So, without wasting any more time, I would request Professor Badlani to start his talk. Over to you, sir.
Thank you so much. I presume you can see my slides. Yes?
Yes, sir, we can see
Yes, sir.
very clear.
Okay, so the topic assigned was bladder outlet obstruction in females. As Uttam mentioned, it is an uncommon entity. However, retention is not. So one needs to understand when a person presents or a female presents with incomplete bladder emptying, how do we go about assessing it? So the goals of today's talk are to learn that incomplete emptying and/or retention has very different etiology in women versus men. Because if a man presents in retention, without too much thought, you schedule him for a TURP, with or without his bladder working. But anyway, the procedure is out there for you to do. That's not the case in women. The role of anatomical versus functional obstruction is what one needs to learn in a non-neurogenic population. In the neurogenic population, the etiology of obstruction is quite different. Those who have spinal cord injury, MS, and other neurological conditions with upper motor neuron causing outlet obstruction is a different mechanism. We will not be discussing that today. So you need to tailor your management to a possible etiology, not routinely put them on an alpha blocker, routinely put them on a Methnicol, as I see very commonly in my travels in India. Those are two drugs very often used in women with incomplete empty. First, always the basis is anatomy and learning about functional anatomy. So in a woman, if you see the urethral length is much shorter than a male, the continence zone is the mid-urethra, but bladder neck by itself is a separate continence mechanism. Bladder neck reflexly opens when the bladder contracts. So it's a pulling up action of the detrusor that causes a funnel of the bladder neck, and then the pelvic floor or the mid urethra has to relax, which actually is the first event, and the urination takes place. Lots of receptors in the bladder and the outlet. We are aware of the muscarinic receptors. The M2, M3 predominate in the bladder body, and you have the beta adrenergic fibers in the bladder body, which allows pressure at low pressure filling. And then there is the bladder neck. Obviously, there is alpha adrenergic fibers and or receptors, but the preponderance of these is very much lower than in a male. So functionally, the use of alpha blockers in a woman has very low proven value and or effect. Majority of the detrusor muscle are M2, M3, and submucosally also there are fibers, but they often today's world would say non-cholinergic, non-adrenergic. So they become relevant in sensory phenomena, the C fibers that occur in interstitial cystitis or UTI. Otherwise, the predominant stretch receptors are M2, M3. We have published on a whole mount bladder in a monkey, in a primate, to show that the proximal and mid urethra work very similar to a human. The distal urethra in a monkey is fused with the vagina, and it's a non-functional component. So if you were to divide the distal urethra as you would do in a distal diverticulum or meatal stenosis, it's unlikely to affect continence mechanism, and thus, the distal urethral function is not a functional component of the urethra. You must remember anatomically that it's a different embryological and different epithelial lining of the very distal urethra. So all lesions in there are treated differently than the proximal 2/3 of the urethra. Functionally, we talk about the sphincters. The internal sphincter is a smooth muscle. In the male, certainly alpha adrenergic play a big role. Sympathetic stimulation via hypogastric leads to closure. It's typically closed during bladder filling. It only opens when the bladder contracts. The distal urethra, the external sphincter, has a striated component, which is your volitional or guarding mechanism. We learn about the dysfunctional striated muscle as a cause of obstruction today. There is also volitional control of the external sphincter in terms of letting go or relaxing, and additional contraction during stress maneuvers, lifting, etc. The nerve component along the proximal urethra is also acetylcholine. That's why it makes no sense to give urocholine, which works, or quote unquote supposed to work, on the bladder and the urethra. It is not a drug that can generate reflex contraction. It's not a drug that can cause contraction per se. It can raise pressure in the bladder via subcutaneous injection, not orally. So combination drugs of alpha blocker and bethanechol, which is available in India, to me makes no sense, but certainly is used a lot. So if you were to summarize the talk before we get started, really, overall, detrusor dysfunction is statistically the most common cause of incomplete bladder emptying or retention in a woman. It increases with age, so detrusor contractility decreases as person ages. This is due to increased fibrosis in the bladder wall, which prevents a coordinated contraction, because bladder contraction occurs from a cell-to-cell transmission through a gap junction, which is interrupted with age. And this fibrosis is often a result of ischemia as a postulate as to why that occurs in older patients. The role of outlet is not well quantified. If there is a board question, what's the probability of outlet obstruction in a woman? I'll have to say less than 5%, perhaps in some series less than 1%. But functional obstruction, which is pelvic floor dysfunction, is what we see a lot, and it's quite a high number in our clinic. So as a cause of incomplete emptying of the bladder. So if you can see in the algorithm, the detrusor dysfunction will be much larger. You have typically presentation is significant post-wide residual. You need to check for prolapse, and your physical diagnosis, whether it's neuropathic or not, is made easier if you examine the rectal tone. If you do a rectal exam and there is no tone, no contraction, then a peripheral neuropathy and or low motor neuron lesion can be suspected. And then lack of bladder activity on a bladder study. On the outlet side, a physical exam of the urethra is key to assess if there is a lesion in the urethra, and then assessing pelvic floor. This is what my main message today would be: learn to examine the pelvic floor, the levator muscle, the tender spots near the ischial spine and or the pubic tubercle on the inside. Those are key trigger points in patients with high tone pelvic floor, which can be a cause of obstruction. Assessment done with uroflow or residual, and in a select cases, a video urodynamic is suggested because urodynamics doesn't give you the site of obstruction. You will see the cases that I share with you today, how much video is helpful in assessing the obstruction. The general exam in any woman with voiding dysfunction is to assess their age and correlated to the age, the causes of obstruction. Prior surgery is very much key today. If you have prior outlet surgery in a woman for stress incontinence, that becomes a key reason for a possible outlet obstruction. Examining the meatus, particularly in older women with postmenopausal status. I've heard a lot of people talk about that being a cause of obstruction. Functionally, though, it has not been proven to be a common cause of obstruction. We talked about the screening methodology and the video urodynamic. Cysto is only relevant in a few key cases. It is not a functional study and should not be the basis for making a diagnosis. Specialized management is needed in select cases. So you start with some case-based learning. A painful retention is often due to a urethral mass. It is anterior vagina, and if you present it, generally, a gentle stripping will cause purulence. Can occur in third trimester or after childbirth. If it presents a patient in retention in the third trimester, one should not proceed to a formal surgery at that point. It can be a bloody mess due to a high blood flow in the pelvic area. If you're forced to manage it acutely and the patient is septic, consider aspiration from the vagina, and if necessary, and if it's very distal near the meatus, marsupialization, that means cutting the ventral meatus into the diverticulum and then suturing the edges is a way to conservatively manage. Otherwise, treating with antibiotic and a catheter is perhaps the best way to treat until the patient has delivered and then deal with the diverticulum later. When a diverticulum is present, one must assess appropriately, age dependent. There can be stone, there can be malignancy. We'll talk about doing an MRI as the best mechanism of showing you can see how large this diverticulum is. That can present as a, pronouncing mass per se. Usually this will not be this large a diverticulum, but MRI is the best diagnostic in terms of assessing diverticulum. Patient presenting with hydronephrosis, bilateral hydro in a female from retention without a neurologic cause, you must examine the patient. If you just see the sonogram and don't touch the patient, you'll miss prolapse as a diagnosis in this patient. And a significant prolapse, just like the prostate, causes severe angulation of the ureters, causing an obstruction. Catheter drainage, use of pessary, is to see if it resolves. If it doesn't, and it has been long-standing, then there is fixed fibrosis at the UV junction, and you may need to do a stenting and or some other technique in terms of relieving that obstruction at the UV junction. These patients, depending on the duration, their detrusor function may not return, and they remain in retention even after corrective surgery for the prolapse, and they may need to be on self-cath for a while. So prolapse has to be significant, that causes eversion or inversion of the urethra, causing an obstruction. On my recent visit about a few weeks ago in Uganda, I saw the most unusual case, which I've never seen in the past. This lady presented with a mass that appeared to be coming from the urethra. It was quite firm, not cystic. She was leaking continuously, so we thought she must be in retention. So we could not put a catheter in, couldn't find the meatus. And a scan done showed the bladder to be empty. She had bilateral hydroureteronephrosis. And exam under anesthesia showed that this was complete eversion of the bladder through the urethra. The bladder had turned inside out through the urethra. Both the ureteral orifices were outside, excreting urine as a cause of leaking. And under anesthesia, we were able to reduce it back into the urethra, back into the pelvis. The urethra was obviously very, very wide. Left a catheter in for 2 days, and but exams, since we're only there for 4 or 5 days, it's hard to leave them long term. 2 days later, the urethra had not significantly reduced, so surgically reduced and plicated the urethra and supported the pelvic floor as a treatment. I don't know the outcome. We left after a week. She had a catheter in when we left, and the plan was to repeat her studies to see if she got improved. So don't have an outcome. The rate of obstruction from prolapse has been described as 4 to 13%. And again, if you take selectively the group that is procedentia or complete eversion of the uterus or the vagina, it's likely to be higher. It can lead to a silent renal failure if not observed. These patients present with ulcerated uterus on the outside and have long-term obstruction. The mechanical obstruction can also occur from a subcervical fibroid. This is uncommon, and the fibroid just is at the distal end of the uterus, just at the cervix, which is pressing on the urethra and causing obstruction. And if you don't do a pelvic, you'll miss that diagnosis. So let me take you through a case. This is a 74-year-old female. She has a long-standing urgency and urgent continence. That's her presentation. She has severe dysuria frequency, multiple UTIs, prior surgery, sling surgery. On exam, she has about a grade 1 cystocele. She has induration at the sling site. However, there is no exposure of the mesh or bleeding. In such a case, you have to assess if the person is in retention or not. Many a times, they're not in retention. They have difficulty voiding. Their flow may be variable. However, if you do urodynamic study, you can see at a low filling volume, very low filling volume, she has a high pressure bladder contraction. that you can see here. Multiple contractions present here. Voiding pressures are high. The flow is very slow. So by definition, this patient has detrusor instability at low volume and high pressure voiding with low flow. Again, what is the characteristic of flow and the pressure? By Blavis nomogram, if the pressure is more than 20 centimeters of water and the flow is less than 12, they're obstructed. So this patient is definitely obstructed. Her prior sling surgery is playing a role. Now, how can you treat this patient? You have two options based on a discussion with the patient. What can you do? Either you treat the bladder overactivity with standard conservative management of bladder training medical therapy. You can inject Botox to slow the bladder down. However, that person will be in retention. So you'll have to adjunct that with a self-catheterization as an option. You can even try neuromodulation to improve bladder overactivity. However, the other option in this patient would be to consider a sling takedown. Now, what's the drawback of that? Depending on how you do your procedure, or if you need to do urethrolysis, depending on the type of material used for the sling, this person can develop recurrent stress incontinence and or ISD. So you have to ask the patient, what do you want to risk, retention versus recurring incontinence, before you manage the patient. So creation of artificial neoligaments based on synthetic sling is a very common procedure today. It's supposed to be non-obstructive or tension-free, that you're relying on that sling tape to be a hammock for the urethra to rest in, not be pulled up to obstruct the urethra. That's not the goal. So by definition, the retropubic slings are likely to be more obstructive. Transobturator tape is less so. Single incision sling, again, less so, but they all can be obstructive depending on how much tension you put on the sling. The other form of obstruction related to the sling is the sling going through the urethra. This would happen more commonly with transobturator tape coming from outside to inside. This can result in the tape going across. Patient presents with obstruction. You have difficulty catheterizing. When you look in, there's a mesh across the urethra. This needs to be treated surgically. The ideal way to do it is vaginally open the incision, approach the sling from outside the urethra on one side or the other, and then cut it across. But, obviously we are endourologists, so we try all kinds of things through the scope, using a scissor, using a laser, and it has even described, depending on the mesh being incorporated in the bladder or the urethral wall, a resection per se. All of these have a high probability of incomplete result, as the fibers of the proline still remain in the wall, and you need to go back. So ideal solution is surgical, and that's what you should explain to the patient. What about sling takedown? The variety of ways of taking the sling. It's actually easier to deal with a proline-based sling because it's easily approachable, identified, and removed and or divided. The fascial sling or tissue-based sling or autologous sling or material that's replaced by fibrosis is hard to divide a sling. You have to do a formal urethrolysis. So my preferred approach is to go in one fornix, and depending on if it's a TOT, it's very up in the fornix. You can just make a small incision, find the mesh, and divide it there. Once you divide it, the tension is released. The middle portion of the urethra is still supported, so you have lesser chance of incontinence. If you cannot identify, sometimes what happens is when the sling is spaced, the cause of obstruction, that it rolled and moved proximally. So or acting like a cord, and it's very difficult to find. There you have to do a formal midline incision from the urethra down to the bladder neck to be able to find it and then divide it. You can also do a U incision and then find the mesh and divide and remove a portion from one end to the other to be more complete, but that increases the risk of incontinence. Formal urethrolysis requires a U-shaped or two parallel incision that you enter the retropubic space, dissect completely, not only paraurethral, but sort of meet your fingers in front of the urethra, complete mobilization of the urethra entering the retropubic space. This has a higher probability of repeat stress incontinence, but is often needed in patients who have a fascial sling or other tissue-based repair where you need to do a formal urethrolysis, making sure that you don't enter the bladder and don't injure the urethra by going laterally and in front of the urethra. So now this is an example of a patient presenting with difficulty emptying a bladder. This is commonly a presentation that we see patients who present with frequency, urgency, difficulty voiding, a sensation of incomplete emptying. When you try to put a catheter in, it's very difficult. They're in too much pain. They won't let you put the catheter in. She's had dilation and a Foley placement. This recurred twice, and a third dilation done in the OR. And the report on cystoscopy, this is a referral report that there was a pale segment of the urethra noted. She presented initially with no voiding symptoms, no urinary incontinence. She wanted a more definitive solution to her recurring problem. History significantly for obesity. She had chlamydia as a teenager. She's had 3 deliveries, currently on no medication. The exam showed normal external genitalia. There was no prolapse or caruncle, no urethral masses or discharge. There was evidence of a mass-like feeling under the urethra, but no fluid was expressed. And when we passed the 12 French catheter, there was some resistance met at the distal third of the urethra with associated pain. We were able to progress and we found 150 ml in her bladder. This is her flow pattern. Anybody wants to comment on this flow pattern? The residual is 170. She voided 173 cc's. So this is typically a person using Valsalva augmentation with stop-start pattern, a significant strain to empty and emptying of the bladder. So prolonged voiding time, stop-start pattern. This is very typical of either dysfunctional voiding or detrusor dysfunction. That means bladder is not working. You're using your belly muscles to empty the bladder. So now here is where the video picture comes helpful, right? To show is there an obstruction. And you can see the bladder, and then there's proximal urethra. Bladder neck is open. There is the mid-urethral halt here. It's called the spinning top urethra. Those of you who have played with the tops know what the shape of a top is. And then you see the distal urethra becomes a normal caliber. So what does she have? A stricture? Does she have mid-urethral obstruction or a pelvic floor that doesn't allow the pelvic floor to relax? So if you have no overt neurological diagnosis, this by definition would be a dysfunctional voider. It can be a part of the so-called Hinman syndrome in children, and they vary in their residual from small to moderate. And they go frequently based on the sensation. They train themselves to go by Valsalva because there's a very small amount of urine present. So you have to take a step backwards in these patients. You have to tell them that don't strain to urinate, and they tell you we can't urinate without straining. And their you teach them to do self-cath to overcome that barrier. And you can use the VCUG or video study in our case, where we suspect reflux, particularly in a neuropathic patient, suspect a urethral diverticulum, after surgery to see where the obstruction is, and sometime in patients who have insensate voiding. This is vaginal voiding that we can show on video urodynamics where it's occurring. Now, when a person with dysfunctional voiding, if you do their urodynamics, you can see there is no instability during filling. When they try to void, all they're doing is Valsalva. And of course, the pelvic floor activity increases when you Valsalva, and the flow coming out, a net effect is very, very poor, and the flow can be interrupted. This is opposed to somebody who has high bladder pressure and slow flow. I mean, those are two differentials in trying to make a diagnosis of obstruction versus dysfunctional voiding. And post-study PVR can vary. Now, this patient had a pediatric scope introduced and anesthesia without difficulty. And when bladder neck was normal at the level of the urethra, we showed the urethra was truly pale, and there was circumferential coaptation around the scope at the mid-urethra, but there was no true stricture or from fibrosis. So this patient had excessive guarding of the pelvic floor that required some training, and sometimes use of vaginal Valium is helpful in these patients, but mostly pelvic floor physical therapy is helpful. You can use Flomax, but of course it's not the site of obstruction. Bladder neck is open, so it's useless. And you may need to support with self-cath initially. And some patients where pain is significant, we will mark where the trigger point or painful spot is and be able to use a trigger point injection with local anesthesia, long acting with some steroid, to be able to break this cycle of spasm using a spinal needle or a metal guard. You can do this under local anesthesia in the office. And then once you're successful, the flow pattern completely changes to an improvement, which is a normal flow curve. So this is a functional bladder sphincter dysfunction, and pelvic floor dysfunction is very leading cause of voiding difficulty in patients. As opposed to that, if you look at this patient who's 59, postmenopausal, with a long-standing history of voiding dysfunction, she has a stop-start pattern. She has been tried with Flomax, baclofen, physical therapy. This patient, now the giveaway of not having pelvic floor as their cause is that they don't have vaginal pain, they don't have pain on intercourse, they may not have bowel dysfunction. This is purely bladder only, as opposed to the dysfunctional voider who's likely to have vaginal pain, intercourse pain, as well as bowel dysfunction. So this patient's had prior cystoscopy. She's been dilated, which is the most common treatment for voiding dysfunction. She's been diagnosed as neurogenic bladder without an overt neurological diagnosis. She's a very skinny lady. She's a PhD, very anxious. And what we then did is, of course, you examine, you look at prolapse, you look at the outside. Everything in her case appeared normal. She had no tenderness of the pelvic floor muscle. She denied speculum exam or PVR of the 160. So what would be her differential diagnosis with her complaints at this point that you have this long history? There's a long list where you can think about a stricture, a fibroid, a mass, a lower uterine segment, and the DSD, and finally primary bladder neck obstruction. Now, how often does it occur? It's extremely uncommon. How do you evaluate? You do a flow rate, As you can see, her flow is very, very low. She has a high PVR of 465 ml. You do a bladder study, and you can see that the pressure in the bladder is very high, and the flow is much slower than normal. Now, here's where video helps. As opposed to the previous video picture you saw, you can see the heavily trabeculated bladder. What you see is the bladder neck is not open. Key is to take the picture when the bladder is contracting to be able to see this. So the diagnosis, again, as we went through, the diagnosis in this case, with the bladder contraction, the slow flow, non-opening on the video is a primary bladder neck obstruction. And you can try alpha blocker, self-cath as a management. However, bladder neck incision is the treatment of choice. Most patients are scared to incise the bladder neck for fear of incontinence, but mid-urethra is a separate continent mechanism, and you can have a bladder neck incision done at 5 and 7. And you need to be careful not to go through to create a fistula. Otherwise, you would be able to treat this. Another example of an older woman presenting with incontinence as well as incomplete emptying. This combination should make you think three things: older patient, incontinent, as well as incomplete emptying. Typically, by definition, if you have incontinence, you shouldn't have residual, right? If your urethra is poorly functioning, you should be able to empty completely. If you're in retention, then you can have overflow incontinence. But if you have just a residual that's not significant to cause retention, overflow is not a situation. So she wears 4 depends per day. She has urgency and frequency as a presenting symptom. She's been tried with medication. By the way, anticholinergics should not be tried in this age group. You should be using a beta 3. And then she has irritable bowel syndrome, GERD. She's had prior surgery and bulking. All of these have been tried on her to correct her leaking. So again, exam unremarkable, no palpable abnormality. What would be the next step? This is her flow pattern. As you can see, the flow is very low, interrupted, stop-start, and the residual is 175 ml. And do urodynamics, what happens? She's got small wave contractions, as you can see, but not a heavy voiding contraction per se. So the urgency is by the low wave bladder contraction, and a voided volume will vary, residual will vary. What's the differential diagnosis here? This is, of course, she has recurrent stress incontinence, but DODU, or detrusor hyperreflexia with impaired contractility, is the diagnosis in an older patient where you have small wave contraction causing urgency as a symptom, but not an effective contraction to void completely. And despite the pressure flow not showing high pressure, low flow, any patient post-sling that presents, you need to consider obstruction despite the pressure flow not being there if you've done a sling and the person has gone in retention. These are difficult cases to manage because nothing is right. You can repeat bulking and Botox, but it is likely to go in retention, so she'll need CIC. So you must ask the elderly lady if she's willing to do self-cath. A rare case where they are bed-bound, nursing home type of patient, you might consider a suprapubic tube and a urethral closure. This is end-of-the-line treatment, not a first-choice treatment. Urinary diversion, again, not a first-line treatment, and depending on the patient's status, you might consider that. In a young patient who's neuropathic, this is a choice. In an older woman of this type, no, it's not a choice. The alternative is to take down her prior outlet procedures, which will improve emptying. However, her incontinence is likely to get worse. So difficult case to manage with no. So to conclude, what I've shown you through a variety of cases, what the differential causes of outlet obstruction are. Overall, though, the incidence is very low in a non-neurogenic population. The post-surgical obstruction is the most common today that I see after a sling procedure. Grade 4 prolapse can, of course, present as retention and bilateral hydro. This requires prolapse management and management of the uretrovesical junction. Primary bladder obstruction is rare but present. It does require a pressure flow study and a video to prove this diagnosis. Functional obstruction of non-relaxation of the pelvic floor is a much more common cause. So of the two most common reasons we see is post-op and this dysfunctional voider. This requires a non-surgical therapy. Meatal stenosis in a postmenopausal can be considered. However, you must show on a video that the obstruction is at the meatus level to consider that as a cause of treatment. This is a difficult diagnosis to make as a patient presents with urgency frequency, but can have varying residuals, and residual gets worse when you treat the urgency and frequency with medication that slow down the bladder further. Now, uncommon causes are rare, is subcervical fibroid, urethral malignancy, stone in the urethral diverticulum. These are all reported cases, not a common diagnosis. I will stop here so that we can chat as to your questions.
It's absolutely wonderful presentation that thank you for all those illuminating cases. My question would be primarily, sir, in this primary bladder neck obstruction, if I can just set the ball rolling. How commonly do you see that in a patient without a neurogenic background? And secondly, how is it different from smooth sphincter dyssynergia in females?
So, smooth sphincter dyssynergia, by definition, is bladder internal sphincter dyssynergia that should occur only in patients with spinal cord lesion at T9 through L1. That's a rare injury in a female, and that's where you should think of. Again, that's relevant only on video urodynamics. The primary bladder neck obstruction in a female without a neurologic cause is again uncommon condition. So there are selective case reports. Perhaps Vic Nitty's paper on it is the largest. He had a case series of 26 cases. But I would say in 30 years, I've found less than a dozen cases of bladder neck obstruction, which I can truly prove on a. So you must only think of it when you see on urodynamic there's high pressure and very low flow, and then you must do a VCUG and or video to see where the obstruction is. Statistically, mid-urethra is much more common as a cause of obstruction functionally.
I'd like to ask you that after you see a patient who may suspect to have obstruction, a female, after you have done a urine culture and the other things, what would be your go-to investigation? Would you believe in going for a VCUG directly, or would you prefer to have a sort of calibration to see if the urethra is patent before you go for a VCUG?
So calibration is not part of my workup, except if you're catheterizing, you're obviously calibrating. Our initial workup is when a patient presents with difficulty in voiding as their primary complaint is a physical exam to examine the urethra and the pelvic floor. And note that if there is associated sexual and or bowel symptoms, so they have presentation as irritable bowel syndrome, voiding difficulty, sexual pain, that patient has high probability of having pelvic floor dysfunction. And a bladder scan at that point will show the residual. If they have frank retention, they get taught CIC right away without waiting for a diagnosis. But if the residual is, somewhat 100, 150, 200, we'd like to make a diagnosis. So we explain, based on our initial assessment, the role of pelvic floor, give them a bladder training program, teach them not to push, strain, have them come back for a flow possible urodynamics. So flow, if it's like the dysfunctional flow I showed you, she'll proceed to a urodynamics with or without video, depending on the patient. And based on that, we will make the diagnosis. So I would say the most common diagnosis in my clinic with incomplete emptying and voiding difficulty is a dysfunctional voider. And then at that point, if there is a surgical history, if the patient's had prior sling and she's in retention or voiding difficulty after, then that's a different track. That person gets urodynamic right away to assess their flow and bladder to make sure the obstruction is the cause, and then they go the possible surgical route. But the dysfunctional voider then gets into the role of physiotherapy and or pelvic floor retraining, trigger point injection, all of those. But if the bladder, she's painless retention, that's likely to be the true dysfunction. So statistically, bladder not working would be a more common cause. Older the patient, more likely is that cause. So they go on CIC right away.
Thank you, sir. And now we have Dr. Nikhil, who has a couple of cases. Dr. Nikhil Khatter was formerly professor of urology at Arm hospitals, and now and later at Medanta. Dr. Nikhil, and he runs exclusively female urology practice. Dr. Nikhil, are you there? Over to you.
Hello, Arvind. Thank you. So whatever remaining time is there, after Sir's talk, already Sir has covered almost everything, but I'll will surely get some more clarity on his approach uh, with the following cases that I have collected for him. Are the slides visible?
Yes, the slides are visible.
So they, these are three cases I have, uh, and we'll quickly go through them. And so this is the first patient. She is a 55-year-old female, and she presented with an indwelling catheter for chronic retention with obstructive uropathy. Before catheterization, her creatinine was high 3.9.
So slides are not moving.
Not moving. Is my slide visible?
Slide is visible, but it's not moving.
No, is it moving now?
No, Nikhil, just put it in a presentation mode right now. It's like we are watching your computer, not truly sharing your slides.
Oh, is it? Just a minute, sir. I will stop the share. I will begin again. Is the slide visible now, sir?
No, the slide is not
We're
at all
watching
visible.
your
Yes.
desktop.
Yes.
Now it
Now, yeah,
is.
now, yes, now, yes.
Okay. Advance. Yeah. Okay.
Yeah.
Visible?
Yeah,
Yes.
you can do full screen though. Yeah,
Yeah.
perfect.
Okay. So this is a 55-year-old female, and she presented with an indwelling catheter for obstructive uropathy, bilateral hydronephrosis with a high creatinine. And on her ultrasound, she had circumferential bladder wall thickening. Catheterization, the note said that the catheterization was difficult and it drained around 900 ml, followed by diuresis. Now, when she presented, the creatinine was settled. There was no history of constipation. There is no prolapse. Neurological examination is normal. Pelvic examination is normal. So, this is a non-neurogenic patient who presented with chronic retention. So, what will be your approach, sir? Like, what will be the first first investigation that you will? Uh,
Well, first, I'd like to know if her hydro resolved.
yeah, it is.
Creatinine is normalized, but if the hydro is resolved, the UV is no longer an obstruction. Um, so then I would like to, this is a patient that needs a bladder functional study to
Yeah.
assess a bladder contractility. A thickened bladder suggests that the bladder is either poorly compliant and or contracting too much against an obstruction. So I'd like to know what her bladder pressures are.
Yeah. So, approach can be from anatomical to functional or from functional to anatomical. Like, so your preference will be from functional first and then to look for anatomical causes, or I'm just,
Yeah, so anatomical in a male can be argued, but in a female, since there is a catheter present already, um, you cannot, by looking in, tell me the urethra is obstructed. You have to show me functionally where it's obstructed. So functional is way more important.
right, sir. So this is her urodynamics, and we can see that there are towards the end of filling there are minor detrusor overactivity changes, and then when we allow her to pass urine, she is obviously obstructed. So, like,
So here you need video to see, or VCUG to see where she's obstructed.
yeah, since we do not have video in most of the places in our facility, what we do is a separate voiding cystourethropy, uh, and this is what we saw here.
Again, based on this visible picture, bladder neck is more likely as a cause
Yes, sir.
because the proximal urethra is not dilated.
Yes, sir. So this we also diagnosed bladder neck obstruction and
So let me
yes,
emphasize
sir.
that while doing VCUG, the radiologist is doing this and you don't know at what sequence is that urethra filled at the time of contraction. That's the advantage of a video urodynamics is to know that at the time of contraction is what's happening and you can see fluoroscopically. I'm just curious to know, you guys all have a C-arm, right? In your places.
Yes,
And you do endourology routinely, right? I mean, in
yes,
your hospital setup. So you have a table that you use for endourology. You have a C-arm and the urodynamic machine is mobile. Why can't you do a video urodynamic when you want to? I mean, it's a rare case that you need it, but you can bring a C-arm and the table and the urodynamic machine. And that's how I started doing videos in the OR. Of course, it's inefficient to do it in the OR and then you bring the C-arm in your clinic if you're doing it often enough. But that's how you get your video aerodynamics initially, rather than relying on the radiologist to do a VCUG. So that would be my suggestion. All of you have a C-arm, all of you have a table that is fluoroscopically compatible, and then You can do the urodynamic machine is mobile, so do a video urodynamic that way.
Yes, sir, that is definitely possible. But generally, the dynamics of the operation theaters work very differently because there one case after the another under general anesthesia is generally there, and that is why it becomes difficult logistically to get the things arranged there. But yes, that is true that with radiology, things are very difficult at times. When to shoot is
Yeah.
really is one has to be very clear that
See, the only disadvantage is you can't get a flow on a table. So
yeah,
I'm just telling you practical. When I got started, and overtime is obviously very, very precious. So I would do these urodynamics on a Saturday when the OR was shut off because these patients are under local and don't need anesthesia in the room. I could just
yeah.
utilize the room on a Saturday with nobody there except my tech. So that's how I did them until I got to see I'm in the clinic.
Mm, yes, sir. So this lady then she underwent a bladder neck incision and is now passing urine normally. Uh, and this is her since the catheterization was difficult. So before my final diagnosis, I also did a urethroscopy properly to know that yes, there is nothing there. So this is another lady there. She is a 45-year-old female with a history of dysuria for 10 years and slow stream for 10 years. She has had multiple urethral dilatations in last 3 years, and each dilatation leading to a relief of 4 to 5 months. But slowly that period of relief is getting uh, lower and lower. She also has constipation, and her pelvic examination is unremarkable. Her uroflow is a poor plateau pattern with a residual of 110 cc. She is not on catheter. Like
So
so, how?
this pattern is more likely to be a dysfunctional voider, pelvic floor dysfunction. They all get relieved with urethral dilation because it causes stretching of the pelvic floor for the urethral muscle for a short time. These are patients who come seeking another dilation. So I tell them, here is a catheter. You can self-dilate whenever you want. You can put this in when you want to feel that dilation. And that's my treatment for dilation. I don't dilate the urethra. Um, but if you do a flow pattern in these patients, you're likely to see a dysfunctional pattern. And there you then need to re-educate them about their pelvic floor, the training, with or without physiotherapy, with or without vaginal Valium. The constipation is again due to the pelvic floor dysfunction. And if you seek further questioning, which is not often reported in your history, is sexual dysfunction or painful intercourse, because all three are affected by the same. Now, of course, in the background is that you could have detrusor dysfunction, and this is a compensation by patient pushing, straining. And if you have a history of diabetes or any other subtle neurological cause, that's where we would go. But on the face of it, this lady is likely to be a dysfunctional voider.
Anything, sir? Like looking at the period for which a dilatation is giving her relief. Now, if that period is more than a couple of months, then generally that is a red flag for me that maybe it is not a that are we dealing with stricture? Uh, do you?
Yeah, I mean, true stricture in a female without prior surgery is again very uncommon condition. Um, but and again, she's 45, which is very young. So meatal stricture in a postmenopausal is likely. Um, but stricture diagnosis of a woman without prior surgery is again an uncommon for me.
When do you consider stricture as a diagnosis? What do you do to rule it in, rule it out? Do you ever consider or not?
Pressure flow study. Pressure flow has to be just like bladder neck, where high pressure, low flow. That means she's obstructed. and then you need to find where the location of the stricture or the obstruction is. So this is the picture like I showed you. Still fits
Yeah.
in with a dysfunctional mid-urethral obstruction. If you scope this lady, like in our case, we didn't find any stricture. You will find some pale urethra because it's being constantly compressed. So this is almost like the slide I showed you. Um, again, in my experience, stricture is less common. So here you need cysto to find out what's happening there under
So
anesthesia.
yeah, cystoscopy, and this is what we find there.
So you see
There is
that
a,
white ring?
yeah, that ring which is not allowing my scope to go further. So, so she has a stricture at this level. And generally, what I have seen is that if patient gets relieved for more than a couple of months, then generally uh, chances of picking up a stricture are like more. Uh, so that is what I have seen. So I wanted to share this. So yeah, this is
So what did you
another.
end up doing? What did you end up doing for that lady?
She already had multiple dilatations. So we did a dorsal onlay graft urethroplasty for her, and she's doing fine after that.
Okay.
This was a couple of years back. So this is the third female. She's a 46-year-old female with history of poor stream and pain in perineum while passing urine for 2 years. Stream is better when she squats and passes urine. So she says that she tries various positions to see where her flow will be better. She also has increased frequency and urgency. There is no urge incontinence though. She has constipation and she is on regularly uses laxatives. Uh, her flow is very, very poor, and she has a thick-walled bladder on ultrasound with upper tracts normal, residual urine of 80 by 240 cc pre-void and 80 post-void. Pelvic floor is the muscles are taut in the pelvic floor. And again, if I go, uh, so this is her mm,
So
urodynamics. And
yeah, picture is similar. You have what doesn't explain is why squatting is better. Only thing is pelvic floor behaves differently when you're
yeah,
squatting versus when you're sitting on a Western toilet. In her case, there is significant Valsalva to start the urination and with continuous assistance by Valsalva despite having a good bladder pressure, suggesting she's trying to overcome an obstruction. Um, and again, you need to scope that patient. Based on history, I would have thought, sometime if you have a sling and or a prior procedure, the bladder tips over on the sling. So it's like hanging on a sling, and that causes this sort of a pattern, and where you need to correct that um, prolapse. This also occurs in sort of neobladders where the urethra stem is fixed and the bladder has tipped over and the empty perineum behind. They will also present this way in terms of
yeah.
situational difficulty. Here, go ahead with the cysto. I didn't see a stricture or anything.
No stricture.
So
No
this
stricture.
was just dysfunctional goiter,
Yeah, this
pelvic
is
floor. Yeah.
disorder has been kept on pelvic floor exercises, laxatives,
So now
and
you see the difference.
normally
The two
in
pictures have no difference. Um,
yeah, both of them no difference in both the pictures, but one had a stricture, the other one did not have.
yeah.
So that is why cystoscopy, actually urethral inspection, proper urethral inspection is one very important step uh, in my scheme of things.
Yeah, but I think it's much more diagnostic after you know the pressure flow. in the sequence that you showed, the cysto is very helpful. If you just went with the cysto first, like in this lady, you would not come up with a diagnosis. You just look in,
Yes.
you find
Yes.
nothing, and then you're still scratching your head. What happened? Why is she having difficulty? But with
Had
the
stricture been the a very common thing, just like in men, then it would make sense to do a office cystoscopy
yeah,
first.
after a flow, yes,
But here, functional obstructions are more common than strictures
anatomy,
or.
correct.
Uh, and another thing that I will like you to uh, just notice is uh, the pattern of detrusor contraction. The pattern of detrusor contraction in these two is a little different. Uh, so there is some studies from India by Dr. Mayank. He is exclusively studying this pattern, and according to his studies, what he says that when we see a plateau pattern here, then it is more chances of dysfunctional voiding. So uh, even without a video urodynamic, just on plain urodynamics, if we see plateau patterns, then there are more chances that there is pelvic floor dysfunction. And I checked on my own diagnosis, and I could also find that yes, there is some sense uh, to that. Have you ever noticed that or anything?
I can't say that one has to have a very significant number to make this as an observation. These cases are uncommon. I wouldn't see more than 10 or 12 in a year of the pictures you're showing. So to make a meaningful observation like that, I'll have to go back and look. There's significant Valsalva effort, and the pelvic floor activity is different in the patient that you showed with dysfunctional voiding as opposed to a true obstruction. Um, that's where the main difference is. There is so much of the abdominal and pelvic floor activity in those patients that sometimes it masks the actual detrusor contraction. And only with net detrusor pressure, you can see that there is actually contraction. That patient with dysfunctional voiding sometimes will have just Valsalva, no detrusor measurable, and be able to, void in a stop-start pattern. So the pattern you showed is true obstruction. The dysfunctional voider more commonly has the stop-start pattern of the flow, not a steady flow, even if it is low, which is typical of obstruction. So a flow pattern is more likely to tell me if the patient is obstructed, if there is a detrusor contraction. The flow pattern is a stop-start in a dysfunctional void.
Dysfunctional voider is also a spectrum, sir.
Spectrum. Correct.
Uh, like this last graph where the detrusor contraction is not peaking to that much, and the earlier one where it peaked to around 80, 90,
Right.
and sometimes even it results in hypocontractile bladder if that HTNRS.
Yeah. If the
And
contraction has been present for a long time or retention, then they turn into a hypocontractile. Just like a male with a long-standing outlet obstruction, their bladder becomes hypocontractile from like giving up, like being on a stretch for too long. At that point, you can't tell if there was truly obstruction or a hypocontractile bladder. So,
yeah, that is one way of them becoming hypocontractile. The other way is the urethra detrusor inhibitory reflex. That also can lead to hypocontractility. And sir, I will like to emphasize one more point that like looking at just the picture on the voiding film, we should not be presuming that they have stricture or uh, not a stricture dysfunctional voiding, because some of them will have stricture, some of them will not have stricture. So that is a possibility, and always nowadays uh, we like 10 years back there were hardly any papers on female urethroplasty, and now we see so many papers on female urethroplasty. Probably they are being scoped, or and that is why these strictures are being picked up.
So again, all these pictures without a sense of bladder pressure are not diagnostic, according to me. So without knowing what the bladder pressure is, that's why VCUG alone should not be the basis of diagnosis. You should know what the bladder pressure and flow is to make sense out of these pictures.
Yes, sir. That is true. But according to one is that Blevas nomogram. The other is NITI's studies, which say that if there is a urethral dilatation, then definitely the female is obstructed, irrespective of the pressure.
Yeah, but like in your case, you showed the obstruction is not anatomical obstruction, it's a functional obstruction, like in your third
Yeah.
case, right?
Yes, sir. And sir, regarding the cystoscopy, or uh, so so I'll just like to point out one more thing before this is my last slide, that doing the cystoscopy with an end-on scope, 0-degree kind of scope, will help you pick whatever narrowing better than the conventional cystoscope, because
Yeah,
that will.
you're right. Today we do a flexible scope, which is in effect a zero scope,
Yes, sir.
which is very helpful in picking up these end on rather than having the beak that just sort of goes through.
Yes.
So in a female urethroscopy, the mistake is by the time you start, you're already in the bladder. You're just putting the scope in the bladder and suddenly you're in the bladder. You never looked at the urethra and you sort of look at it on the way out. So in patients like this, you have to put your finger at the meatus and support the scope and go slowly in as you go in to assess the urethra.
Yes, sir. Right, sir. So I'll stop my
So
share.
So it's absolutely wonderful case discussions there. I just like to ask two small questions to Professor Badlani. One is about female voiding. With female voiding, and look at female voiding, there are actually many normals. Some females void with a detrusor contraction. Some of them void with just relaxation of the pelvic floor. Um, why is there so much heterogeneity in female voiding, and male is more or less uniform? That is contraction, relaxation of the bladder, neck, and then the sphincter, and it's more or less uniform. Why is there so much heterogeneity in female voiding?
Ajit Vade had once asked me to give a talk on why female pelvic is such an enigma. And actually, I have done that talk once before to show you all the things that are like, defy reasoning or logical explanation. So my assessment is bladder is a smart organ. It works only as hard as it has to. So if the outlet resistance is low, it doesn't need to contract. So just simply lowering while you're doing urodynamics, the rectal line declines, the bladder line, nothing changes, and they have an excellent flow because just the pelvic floor relaxed and they void it. And as it has to be in context of the complaint. If the patient has no voiding complaints, then whatever the detrusor pressure is doesn't matter. If they have voiding difficulty, then detrusor pressure becomes relevant. Then again, you have to differentiate, is there a lack of initiation or lack of contraction? I mean, she couldn't initiate voiding in your presence. That doesn't mean she has an acontractile or areflexic bladder. Then again, I have to correlate to her flow. If her flow is normal, the absence of contraction again makes no difference. So the contractility of the female urethra is very variable, and its relevance depends on their flow and emptying. If the flow and emptying is normal, the pressure is irrelevant um, in that regard. Sometimes I go by a super flow pattern. I mean, nothing else was fine. Ladies complaining of stress incontinence, you can't demonstrate stress incontinence in the clinic because she's guarding at the time of your testing. She's aware and she's not leaking. But her flow pattern shows a peak flow of 35 cc's per second. Well, it shows outlet resistance is low. So it's consistent with her diagnosis. Whether you choose to operate based on that or not is different. But certainly, those are all corollaries to what you find in your, overall assessment of the patient. So that's why I say symptoms, my whole emphasis on symptom-based diagnosis. Urodynamic is to prove a point, but your diagnosis, at least for me, I often have a hypothesis or diagnosis at the time of listening to the patient, what her complaint is, and then say, well, does that correlate with my findings?
There's just two more short questions. One, we've all seen bladder decompensation in females and males. In your experience, how many of these bladder eventually recover to extent where they're functional again?
So, in our retrospective study of male patients who presented with, significant initial residual or retention, only duration of retention was a correlate to how soon or how late that the contraction came back. And that information is rarely available. How long were they in retention? So acute retention is 5 to 7 days. Generally, you see recovery. The best correlate you can find is in patients who have post-hip or orthopedic surgery, where orthopedic used to hate putting in catheters in them, and the first cath volume is 1,200 cc's in the recovery room. Those patients are now in retention because it's an older female, bedbound, in pain, and her bladder has been stretched to 1,200. Now they've really altered the course of that treatment. And I had a series of these patients where I told the orthopod, please, I know you hate putting in a catheter, but the end of your surgery, just straight catheter once. And that killed my business because I wasn't getting any more of those referrals. So over distension is a known cause of the injury to detrusor, but duration is most important. Unfortunately, in some of the neuromodulation cases, I've tried like before and after neuromodulation. In all my years, I can only show you one case where you can show the detrusor contraction after neuromodulation, where we thought she was non-obstructive retention. So bottom line, I don't know the answer. How long does it take to come back?
And then one last question, sir. Do you believe before urethroplasty to prove obstruction is important because that improves the outcome? And that's what I have seen in my practice. If I do aerodynamics and I prove obstruction, then the outcome of my urethroplasty is so much better. If I do urethroplasty, sometimes it has happened on underactive detrusor with outlet obstruction, the stricture, the outcome is not as good.
Yeah, I mean, there's nothing worse than taking a dysfunctional voider and doing a urethroplasty on her. You just have such a sad post-op course because she never really got better, a primary problem, and now you've instrumented and operated on her. So, like Nikhil showed, you got to show that the pressure flow shows obstruction. You locate it. Yes, you may need endoscopy, but fluoroscopy shows you where the location and you correlate with the endoscopic findings and then operate, you're much likely to succeed.
Then thank you so much. It has been such a wonderful 1.5 hours almost. Yes, ma'am.
I was wanting a little clarity on the pregnancy-related obstruction, which we see is in the 4th month and sometimes in the postpartum period, because they also are pretty common patients. So here the etiology you would see.
If I heard you correctly, you're saying retention in the last trimester or postpartum. Is that what you're?
Yes, sir. Yes, sir.
I mean, those are not worked up immediately. They are put on self-cath and waiting for their few weeks to pass postpartum. And if they haven't improved, then we do urodynamics. We wouldn't do any immediate workup in them unless there's traumatic delivery or injury during delivery. Otherwise, straight retention, we would just put them on CIC for a few weeks for the edema and the swelling and all that stuff to get down. At the end of 4 weeks postpartum, if they're still in retention, then we would do a bladder study. Time
Okay, sir.
is what we offer them.
Thank you, sir.
Do you think these ladies who develop postpartum retention, they already have some pelvic floor dysfunction beforehand?
I think pain leads to excessive guarding. So you have a patient with back pain or hemorrhoidal pain, they present with retention. And the only correlate is pain-related excessive guarding that does not allow them to relieve their pelvic floor to be able to urinate. So certainly delivery is a painful situation, and what trauma the pelvic muscle has gone through or the urethral edema has occurred, all that are potential correlates. I don't know if there is a way to assess them at that point. Acute study in these patients is not often possible or done. So giving them time, particularly if they can do self-cath, is helpful. If they cannot do self-cath, then it becomes more of a problem for everybody. They're running around with a Foley catheter and they want to get rid of the catheter, and each person keeps giving them trial or void. You can't give them medication because they are breastfeeding. All of these are just practical problems, easily solved if they agree to do self-cath. So having a team of nurses and or somebody who can teach them self-cath, and oftentimes in these patients, having a male Coude plastic catheter is easier one to teach rather than a short female urethral catheter. So they can hold further away, and the Coude allows the catheter to go in the urethra easier. And so we teach them with a male catheter, often with standing position with one leg on the toilet. And they put their left finger in the vagina and use the right long catheter to go along the finger into the urethra to teach them how to do self-cath.
Wonderful, sir. Thank you so much we really benefited from your experience and knowledge. And I request Dr. Uttam, sir, would you like to say something
No,
before we?
sure. I was there throughout the whole presentation. Definitely, my area of interest is oncology. But still, I just want to ask one question. So, what is the long-term outcome or follow-up of bladder neck incision? Like,
Well, I mean, if you do it correctly, majority of them do quite well. You have a lifetime of obstruction or long-term obstruction that they relieve. Some of them still need self-cath as a supporting mechanism for a while after, depending on their bladder activity, whether they've decompensated, etc. So in general, if the diagnosis is accurate, doing an effective bladder neck incision. The drawback is doing what I call a half-ass job. You really haven't incised it properly. You just scratched the mucosa because you're scared it'll cause incontinence. So you don't do. So you need a proper Collins knife. It's a very short incision just across bladder neck. Unlike a TUIP or other, you're just cutting bladder neck alone at 5 and 7. And you can see the letting go of that muscle if you do it correctly.
thank you, sir. Thank you very much for spending some time for us. And we look forward for your participation and teaching in future also, sir. It will be of great
Wonderful.
benefit to the USA, sir.
Great to talk to you guys. Nikhil, wonderful pictures. Would love to share some things with you. Bye.
Thank you.
Thank you very much, sir. Thank you, Nikhil and Arvind, especially for conducting this session so
Thank you, ma'am.
efficiently. And thank
Thank
you,
you, sir.
Dr. Uttam,
Thanks,
Thank you,
for
sir.
Arvind. Thank
Thank
you,
joining
you.
Dr.
Thank
Dwiti.
you. Thank you.
Yeah.
Bye.
and USI Central Office too. Thank you very much. Good night.
Thank you. Good night.
Good.